glad you joined us today. We have business school alumni, we have current students whom we miss very, very much at Brandeis International Business School. And we also have staff from Brandeis and Brandeis in the International Business School joining us today. So we're grateful for all of your participation and attendance, and we hope you can stick around to the very end. But if you have to jump off sooner, that's completely understandable as well. We wanted to do a lunchtime faculty talk to capture as many people as we could, but we know during this environment, in this existing world we're in, there's no perfect time to capture everyone, but we're grateful for those willing to join today. So thank you. First off, my name is Shane Dunn, and I am the Senior Director of Development and Alumni Relations at Brandeis International Business School. Before we get started with our program, I want to outline a few ground rules to help us conduct a really excellent experience for all attendees as well as our speaker today via this virtual environment on Zoom. We too, of course, at the business school are figuring out how to best engage folks virtually. We have more programming coming that I'll mention to you later today. Brandeis is continuing to experiment with how we engage folks. And we know there's obviously a range of other programming that folks are engaging with online currently. So we're doing our best here, and I think you'll have a good time today. But it does start with some ground rules to make sure you have a stimulating experience. The first is, if you have not already or we have not done it for you, please mute your microphones and also turn off your video. It will just help us with bandwidth control. At some point, if you want to speak or you are given the chance to speak, if we get there, you can definitely turn your video on. But right now, please mute and video off. It will just help significantly. Thank you. The second piece is, if you've not done so already, please make sure your name is updated. It's pretty easy. If you click the three dots next to your screen in the upper right-hand corner, you're able to rename to whatever you want, but we of course hope you put your name in there. And you should feel free, because we have people in a lot of different areas, to put where you're from. Are you in Boston or Massachusetts? Are you somewhere else around the world, around the country? It can't hurt, just so we can kind of try to build some engagement and connectivity together as a group. And then the final thing is, you should feel free to use the chat as much as you'd like to connect with folks. If you see them, feel free to send a private chat. That also will be the way that we do questions and answers with our speaker throughout this session. So the first thing I'd like to do before we jump into the formal presentation is take a quick poll, which I think will be popping up shortly. Yeah, here it is. So those of you who are able to see this, we have a quick poll. We're just trying to get a sense of who's with us. We have alumni, we have current students, staff, faculty, parents, or other. So we're going to take about 30 to 40 seconds here just to get everyone voting. We're going quickly. Thank you. Nice. So that looks like 6 or 7 people still need to go. 5. 10 more seconds, 4 more people. All right, I'm going to end the poll. We have 90% of participation. Thank you all. So we actually have a lot of staff on the call, which is wonderful. So I know we have staff at the business school. We have staff in other parts of the university. So we're grateful to staff who are interested in hearing from Professor Scherbina and just connecting with others. We also have several alumni. And as I said, we also have faculty and parents, but it's also great to have a handful of students on the call with us today. I know you all are spread out around the world and your whole semester was upended, but we're hoping you're having a good experience right now. And we're glad we at our team and at the business school could bring you a little bit of additional content to your experience this semester. So I'm going to now move us on to why you all are here, which is to hear from our speaker. I am grateful that today we have Anna Scherbina, an associate professor of finance at the Brandeis International Business School, joining us to talk about her research on the potentially and now real health and economic losses in the United States due to the COVID-19 pandemic. Anna will speak about her background and research for about 20 to 25 minutes, and then she will take clarifying questions Or if you think there's something that you actually want to share throughout, you should join us and engage with us via the chat window, and we'll try to get to your questions during our presentation. If not, we'll do a Q&A at the very end. Our goal here is to be done right around 1:20 p.m. Eastern time so that folks can get back to their days, including Professor Scherbina. So feel free to use the chat window throughout. We'll do our best, and I will do my best to moderate this. And I hope it's a really good experience. So I'm now ready to turn it over to Professor Scherbina. Anna, please go ahead.
Okay, hello everybody and welcome. And thank you Shane and Gina for setting everything up and for inviting me to give a talk. So I will right now discuss my, okay, let me advance the slide. Okay, so I hope you're seeing slides advancing. So this is the topic of my talk today, evaluating the optimal health policy response to the COVID-19 pandemic. And this is based on the paper that I recently finished. So actually I just updated the paper with the new data because everything is changing so fast with this pandemic. The number of new cases is really growing exponentially. So the conclusions have changed relative to the paper that is published on the AAI website and on SSRN. And today I will present the results with the newest data. So first, let me quickly talk about my background. I have a PhD in finance from Kellogg, Northwestern University. And prior to joining Brandeis, I was also a professor of finance at HBS and UC Davis. I am currently also a visiting scholar at the American Enterprise Institute. And for the last 2 years, from 2017 to 2019, I worked at the Council of Economic Advisors at the White House as a senior economist. And you know how economists, they are responsible for different topics that they cover. So my main topic was obviously finance and fintech. I also looked at artificial intelligence policy, things related to technology. Obviously, because there were so many things on trade, I worked on trade as well. I did a lot of work on cybersecurity, which kind of opened up my horizon to how important cybersecurity is in the current environments. And I also worked with the National Security Council, with the people who work on biothreats. So that's a topic. So the National Security Council also is divided by topics. It's the largest component in the White House. And one of the departments handled biothreats. So with them, I worked on the executive order to develop better vaccine technologies to fight influenza. And I was one of the authors of the CA paper on pandemic influenza, where we analyzed the possibility of pandemic influenza coming to the United States, analyzed what could happen, did a model of pandemic influenza. And you know, the conclusion of that paper was that we need to develop better and faster and more scalable vaccine technologies, because that would help us not only in the case of a pandemic, but also in the case of seasonal flu, which nobody really talks about, but it's really deadly, especially in some years when the strain is a little bit different from what we prepare for. It could be really highly deadly, and it could be tens of thousands of deaths. And little did I know that coronavirus also poses a threat. And so I actually used a lot of that knowledge that I developed to write a paper about COVID-19. So COVID-19 pandemic turned out really a serious threat. I looked up the numbers yesterday, and right now we have over 500,000 total cases in the US, and almost 22,000 deaths. And because we know that there's no widespread testing, a lot of people want to get a test, they cannot. And some people are really even discouraged from going and getting tested. Like in New York City, the system is so overwhelmed. People are not getting tested, for example. And you could imagine people with the milder cases don't get tested. There's speculation that maybe the number of cases is twice as many. And that's the assumption that I used in my analysis right now, that we've had about 1 million cases so far in the United States. So unfortunately, right now, we don't really know too much about this COVID-19 virus, but we know some things. So we know that this virus is very, very contagious. It's actually more contagious than seasonal flu, obviously, but also more contagious than pandemic flu that we analyzed in the paper with the different scenarios that we analyzed. It's more contagious and also more lethal. So if you look at the infection fatality rate, how many people who are infected end up dying, we don't really know what it is for sure because we cannot really observe all the infections because, as I said, not everybody gets tested. But some speculate in their published papers that it's maybe 10 times deadlier than seasonal influenza. So with seasonal influenza, only 0.1% of the people who get it die. With this virus, some speculate maybe as the infection fatality rate could be as high as 1%, as many as 1% of people who get it die. And some speculate it could be even higher than that. And obviously, it very much depends on where you're looking. If you're looking in Italy, where the population is older and there are a lot of smokers, the fatality ratio is higher than maybe if you look at Germany, where maybe the population is a little bit younger. So what we also know about this virus, and again, how it's different from influenza, is that while flu poses a higher risk for both children and older adults, with COVID-19, it seems like children are not really that much at risk. It seems that the probability of dying and probability of developing severe complications is much higher for older adults. And what is true about COVID-19, and it's not necessarily true for pandemic influenza, is that nobody has any immunity to it. With flu, sometimes older people you may find have immunity because they were exposed to a similar strain of flu sometime back in the day. But with this COVID-19, it seems like nobody really has any immunity to it. Okay, so this is what we know so far. And before I get into my model, I just want to introduce some very basic terminology so that we're on the same page. And this is something that's the first thing that I learned when I was working on the pandemic flu paper, the R naught. So what is the R naught? Everybody talks about it all the time. So for any kind of virus, R naught is very important. It's the basic reproduction number. So it measures how infectious a virus is. So when a pandemic is just starting, and at the start nobody is immune, it measures how many people on average an infected person infects over the course of their illness. So with COVID-19, we know that people are infectious for the next 2 weeks. So this is over the 2 weeks that a person is sick with COVID-19, they infect R naught people on average. So R naught is important because if it's less than 1, it means that the epidemic is dying out. Each person infects less than 1 person, so the number of new cases is decreasing and eventually it will decrease to 0. If R naught is greater than 1, then you will see a number of new cases initially increasing, then reaching a peak, and then starting to decrease naturally because there are more and more people develop immunity. So when you meet somebody randomly, there's a higher and higher chance that whoever you meet is already immune, so the pandemic just dies out naturally. And just to put R naught into perspective, for seasonal flu, it's on average across all the different studies. There was a paper analyzing R naught for different seasons of flu. It's on average 1.3. So it's neither high nor low, it's 1.3. So it means that, you know, the number of people is increasing initially and then starts decreasing. So it's not really high because we know that we get vaccinated for flu and people have immunity from previous strains. So that's why it's not huge. For Spanish flu, right, everybody talks about it right now because that's the pandemic that is on everybody's mind. Analyzing the studies based on the data, R naught was higher than for seasonal flu. It was somewhere between 1.4 and 2.8. For Ebola, R naught is relatively high, between 1.5 and 2.53. With Ebola though, so from my work, I remember people said why it was easier to contain Ebola is because people who are asymptomatic, they're not typically infectious. So you could tell who is infectious because they have the symptoms. And with flu, it's very tricky because people could be asymptomatic and still infect others. And it's the same with COVID-19. It's very, very tricky. You cannot just measure people's temperatures and say you're not infectious. So that makes it very difficult. So measles, you know, how everybody talks about outbreaks of measles. R0 is really, really high. It's between 12 and 18. With COVID-19, it's not as high, but it's really, really quite high. Like I said, it's higher than what we assumed in different scenarios for pandemic influenza. So different people have different estimates for what R0 is for COVID-19 based on different studies. Some studied the China, some studied the Princess Cruises, you know, this cruise ship where a lot of people got sick. So there are different estimates between 1.5 and 3.5. I will use the same assumption for what the natural R0 is. It's the same as in this famous Imperial College paper. I'll assume that the natural R0, the non-intervention R0 for COVID-19 is 2.4. So that means that each person who gets sick at the beginning of the pandemic, when nobody else is immune, on average over the course of their illness will infect 2.4 other people. So the infection will spread really fast. Okay. All right, so what happens? So this is what my model shows, assuming that R0 is 2.4 and the person who is sick for 2 weeks. So that's the period over which they infect 2.4 other people. What will the number of new cases look like? This is what the pandemic curve would look like. And, you know, so of course, I use my own model parameters. You could plug in different R0, you could plug in a different number of people who are initially infected, you get something a little bit different. But this curve actually looks very similar to what the curve looked like for this Imperial College paper that came out at the beginning of the pandemic. So I assume that I assume that R0 is 2.4, same as they. I assume that initially, right now, 1 million people were already infected. And so this is what it looks like. The number of new cases increases really, really fast in the beginning. Then it reaches a peak sometime in the beginning of, or in the middle of June. And then the number of new cases start decreasing, eventually decreasing to 0. So why the number of new cases initially increase was because nobody is immune. You meet somebody randomly, you're very likely to infect them. And eventually, there's this herd immunity, what everybody talks about. When you meet another person, this person has a higher and higher chance to have been already sick and to have developed immunity. So that's why the number of cases drops. And you see, because this pandemic is so infectious, it moves really fast. So the peak, if you don't intervene, the peak should have come really fast. And so how many people will end up getting sick if we did not intervene? So how many people are sickened by a pandemic? It's called the pandemic attack rate. So I calculate 56% is the attack rate. So 56% would have gotten sick without, you know, with the symptoms if we did not intervene. And using the infection fatality ratio that I calculated from the CDC reports, and I assume that the Center of Disease Control can only observe 50% of cases because the other 50% just don't get tested. So I calculated that infection fatality rate is 0.7%, so that COVID-19 is 4 times deadlier than the seasonal flu. So I calculated that 1.3 million people would have died. And so if you translate those numbers, people getting sick and people dying into dollar terms, and I will explain how I do it in just a second, I would calculate the cost to the economy would be over $9 trillion, which is over 40% of the US GDP. So how do we calculate the cost of the pandemic? So the cost has 3 components. The first is that people who are sick, they cannot really work productively. They have to take the time off from work, and so their productivity drops. Second component is that some of those people are so severely ill that they have to go to the hospital, and medical care costs a lot of money. And then the most important component is the people who are dying. Each death is a loss to society. We would pay money not to die, right? We would pay money for medical interventions in order not to die. So you could actually quantify the cost of life. And I have, so the cost of life is quantified through the value of statistical lives. I use an estimate from a paper from Aldi and Viscusi for people in different age bins. So on average, the cost of statistical life in my sample is over $6 million. Because so many people will end up dying if we do nothing, the total cost of a pandemic would translate in over $9 trillion. So looking at this astronomical cost, we know that doing nothing is not an option. Then even though we don't have a vaccine and we don't have any effective treatment, we have to intervene in some other ways to stop the spread of this pandemic. Okay, so what can we do? So what we're going to do is the non-pharmaceutical interventions. And this is something that has been done during the Spanish flu in the 1980s. So non-pharmaceutical interventions are described in this famous Imperial College paper by Neil Ferguson and his co-authors that just came out. And it's also described in the Roadmap to Reopening, a policy paper by Scott Gottlieb and his co-authors. Scott Gottlieb was the former FDA commissioner who just stepped down recently. So what do those non-pharmaceutical interventions entail? The first phase is suppression. So we're trying to suppress the virus. We're trying to reduce the number of new cases to the point that we can manage the virus better. And this is what we're doing right now. We're in this lockdown phase, which is the suppression phase. And you have heard that it's working because what we're doing is we're reducing the chance that each person meets other people and passes on the infection to others. That's what the social distancing is all about, making sure people are not meeting as many other people, because we don't really know who is infected, who is not. So just reducing the number of meetings helps us contain the virus and reduce the number of cases. The goal of a suppression is to bring R0 to below 1, to have a reduction in the number of new cases. And that's what is happening right now. It seems to be working. The number of new cases is dropping. Even though the number of deaths, it seems like it's not dropping yet, but it's because people who got sick maybe 3 weeks ago are dying right now, but the number of new cases is declining. And yeah, how do we do this? We just don't let people meet in large groups, don't let people go to church, close non-essential businesses, ask people to shelter in place, and so on. So what happens next? So if you look at Scott Gottlieb's plan, by the way, he has the 4 phases. He doesn't really call them that, but he calls this phase 1, suppressing the virus. The next phase is going to be mitigation phase. We're not going to just return to normal. We're going to try to mitigate the virus. So we're going to reopen the economy to some extent, but still discourage people from meeting a lot of other people, because we still want to reduce the chance that the virus will be passed on to others. The goal of mitigation is to bring R0 to a value lower than its natural reproductive rate, so a value lower than 2.4. So if you read the Ferguson paper, probably through the mitigation phase, because the restrictions on people's lives are not as drastic as during the suppression phase, you will naturally meet more people. So they are arguing you cannot really reduce R0 to below 1, but you could have it slightly above 1. So it will still spread, the number of new cases will still grow, but it just won't grow as fast as if we did not intervene. And people ask, what could mitigation entail? We're still trying to figure it out. And this is why there's all this discussion about how do we reopen the economy and not let so many people get infected. So I think we're still going to very much encourage the elderly, the vulnerable population to do social distancing. We're still going to ban large gatherings, but we're going to ask people not to fly, to ask people to work from home as much as possible. And if we get the number of new cases down low enough, we could probably do a lot more in terms of contact tracing and isolating people who we think are infected. because it doesn't really make sense to isolate everybody if we could then identify who is infected and who came into contact with an infected person and just isolate those people. And with a lot of testing, if that becomes possible, we could identify people who are immune, and those people can return back to work and perform critical functions, for example, in the healthcare or in law enforcement or in the military. So that's the second phase, and we will see how well that's going to work. I guess we're learning from China, and we're going to learn from Germany that is about to reopen, and see how to best do this. The next phase, according to Scott Gottlieb's plan, is immunization. Once a vaccine becomes available, we will start immunizing people. He's proposing we immunize people who are more susceptible first, like the elderly and people with health problems, and eventually everybody else. And then phase 4 is what we haven't really done after the last pandemic. We need to actually restock our medical stockpiles and prepare for the next pandemic threat. So the central question that I'm trying to answer right now, and that's what's on everybody's minds right now, how long should this lockdown phase 1, last? When should we start reopening the economy? Some people say we should start reopening already at the end of this month. And you see governors arguing that that's too soon. De Blasio wants to keep schools in New York City closed throughout the summer. Some people argue it should go on until at least the end of August. And Bill Gates says it should go on for another 10 weeks. So how should we think about it? So this is what my presentation is all about. Okay, so this is what I try to analyze right now in the study. I say, what happens if suppression is lifted now or after 4 weeks? Nobody's talking about right now, but after 4 weeks at the end of April, beginning of May, what happens if suppression is lifted and we go into this mitigation phase until the vaccine is available? Nobody's talking about fully reopening the economy until the vaccine is available. We know that we have to do something until some kind of treatment is available. So this is my baseline scenario. We reopen the economy at the beginning of May. And then they say, well, compared to that, do we gain anything if we extend suppression a little bit longer? What if we extend it through the first week of May, the second week of May, and so on? Do we gain more than what we lose by limiting the productivity of the people through the lockdown? And so what I compare is this trade-off. Do we gain more by using suppression for more weeks and preventing more people from getting sick and dying at that time and also in the future? Or do we lose more because economy is obviously less productive, people working from home, working parents are less productive? So what is this optimal trade-off? And this is what I do this cost-benefit analysis, say what is the optimal time when the benefit of doing the lockdown stops being higher than the cost of doing the lockdown. So that's the point that the lockdown should be lifted. Okay, so to analyze this, let's go back to understanding what happens when a person is infected. So we will first try to understand the costs of the pandemic and how to quantify them. If a person is infected, they could be symptomatic or asymptomatic. And you hear a lot with COVID-19, some people just say they never have any symptoms. But of course, the troubling thing about this is that people don't have symptoms, but they still go on and infect others. So that's why we want to quarantine everybody, right? So a person who is, and by the way, that's the same thing with the flu. Some people just don't develop the symptoms, but they could still infect others. So if a person is infected and they're asymptomatic, they are fine, they're not going to die, they don't really take the time off from work, they don't become sick, don't use any medical supplies, etc. So they don't really impose any costs on the economy. But the problem is with people who develop symptoms. The symptomatic people could have a very mild case and maybe just take a little bit of time from work, but they don't really require any medical interventions. Or they may get a little bit more sick and maybe have an outpatient visit and maybe use a little bit more of medical services. They could have a worse type outcome where they would actually end up hospitalized and use medical resources a lot, but then they will survive. And the worst type of outcome is that a person becomes ill, they get hospitalized, stay in the hospital, and then eventually die. So those are the different outcomes that could happen. And then we try to quantify the cost of each of those outcomes. Obviously, asymptomatic people is not costly, but the cost of each person is increasing the more severe their condition is. And so what are my assumptions? Of course, I don't really know what's going to happen in the future. And at this time, we don't really have, or at least I don't have a lot of data to know how well the suppression is working. So far, we know that it seems to be working because the number of new cases is dropping. So I use two different assumptions for how well the suppression period, this lockdown period, is working right now. My more pessimistic assumption says that we're able to reduce the R0 to 0.7. It means that each infected person right now is infecting 0.7 people on average. Why are they still infecting people? Well, you still can infect people in your household because you live with somebody. You still go to grocery stores. You can infect people there. And you can infect people in the hospital if you end up in a hospital. So then those people infect 0.7 people on average. If we think suppression is working better than what I assumed, I also use an optimistic assumption that would drop R0 to 0.5. So it means that each infected person only infects half a person on average throughout the duration of their illness. So what's going to happen next when we go to mitigation? As I said, that's a big unknown. We just don't really know how that's going to work. I wish we had a good and very clear plan what we're going to do, but we just don't really have it at this point. So it's a lot of speculation. So I assume that if we drop the number of new cases sufficiently enough to below 50,000 cases, we could do a lot more than if the number of new cases is higher. So if we drop the number of new cases to less than 50,000 cases, we could identify sick people and also do a lot of contact tracing. So say you got sick, who did you interact with in the last 2 weeks? Let's go and isolate those people as well, because they may not have any symptoms, but they may be contagious. So let's isolate them. And through this, we could drop the R0 to 1.1, just slightly above 1, meaning that the number of new cases will increase, but very, very slowly. And if we still have a lot of new cases, over 50,000, I assume that mitigation, all these restrictions on large gatherings, encouraging people to work from home, encouraging people not to go to concerts or churches, could achieve the R0 of 1.3. So that's something kind of on the order of magnitude of seasonal flu. So that's, I think it's reasonable. And of course, if we don't really manage, then mitigation could have an R0 much higher than that. So then my analysis would not be right. Then we should keep suppression even longer. I'll talk about it in a little bit. And so, yeah, I think I'm kind of running out of time a little bit. Okay, so let me move on. So I have some additional assumptions that I talked about. I assume that 60% of people are symptomatic, 40% are asymptomatic. That's based on the data that is coming out. Only 50% are diagnosed. So right now we're starting with 1 million people being immuno-infected. And so what really my research shows is that if you keep the suppression in place, so let's start with R0 0.7. If you keep the suppression, let's look at the first graph, which is on the upper right. If you keep the suppression in place for only 4 weeks, and then you go to mitigation, you see how the pandemic curve rises and falls before the vaccine becomes available 18 months from now. That's my assumption. So really, it does not really achieve as much as it could have. We could have just gone to mitigation right away. It would be the same exact outcome because the pandemic curve will play out before the vaccine is available. What if we stop the lockdown after 8 weeks? Look at the next graph on the right, the upper right. You see that now the curve moves forward in time, and the right tail is a little bit cut off, to some extent cut off, because the vaccine becomes available. So let's go to the lower left corner and look at what happens when we keep suppression for 12 weeks. Now it looks actually better because the entire pandemic curve doesn't really have a chance to build up because it's cut off by the time that the vaccine is available. And let's look at the graph on the lower right. If you keep suppression in place for 17 weeks, then the pandemic curve just doesn't really have a chance to build up at all. You're running into the time that the vaccine becomes available. But the question is, does it make a difference, a big difference if you do 12 weeks versus 18 weeks? do you really achieve that much relative to the cost of the lockdown? And I say, no, you have to stop before 17 weeks because the gains at some point, they stop. They start being higher than the losses from the cost of the lockdown. And if you switch to 0.5, you see that because we achieve much more with suppression right now, if our not of suppression is 0.5, if it's working so well, you could actually stop it faster because it reduces the number of new cases so much more in a shorter period of time that you could stop it sooner. And when you go to mitigation, you won't have a lot of time to build up the pandemic curve before the vaccine is available. So that's kind of the bottom line. And so if you look at the incremental savings for extending suppression beyond 4 weeks, you see on the top, you have the graph with R naught equals to 0.7. That is assuming that suppression is not working as well as the bottom graph. So you see the returns of extending suppression by each additional week beyond May 1st are really high for a while. So it really makes sense to keep extending suppression by more and more weeks beyond May 1st. But at some point, you see that the curve flattens out. So it means that even though there are additional benefits, the increase in benefits of extending suppression beyond a particular point don't really necessarily exceed the costs of a lockdown. And that's the whole point. So then I tried to estimate what the cost of the lockdown may be, incremental to mitigation, because we know we're not gonna just reopen the economy to the way it was before. We'll still have to do mitigation. We'll still have to stop people from gathering in large numbers. So I estimate that those incremental costs of the lockdown are $36 billion. So let's look at those graphs. So when do the incremental benefits of the lockdown remain higher than the incremental costs of the lockdown? So if you look at the top graph, when R naught is equal to 0.7, the incremental benefits are higher than the cost for the next 17 weeks, and then actually drop below. When R naught is equal to 0.5, the incremental benefits are higher than the cost for the next 9 weeks, and then they drop below. So if we believe that suppression is working really super well right now, that R naught is equal to 0.5, then we should keep suppression in place for the next 9 weeks till sometime in the beginning of June. And if you do that, you are able to save the economy $3.7 trillion, which is 17% of the US GDP. How? Because you prevent people from getting sick, from missing work, from using medical resources, and from dying, which is something that we need to quantify. And so then, if you think that the costs of the lockdown are higher than expected, then you should optimally shorten the time of suppression. If you think suppression is not working as well as what I assume, then you should optimally extend it, because then you could reduce the number of new cases more, and you could go into mitigation with the lower number of new cases. And if you think that mitigation is going to work worse than I expected, then you should optimally extend the lockdown for a longer period of time than what I calculated there. And then I have some thoughts about how to best reopen the economy. So maybe right now I don't really have a lot of time to talk about it, but that's along the lines that I talked about earlier. Maybe it doesn't really make sense to lock down and prevent everybody from working to the same extent, because some people are healthier, so they have lower risks. And especially if they don't interact with other people, if they don't really have anybody to live with, then they have a relatively lower risk of passing on the infection to others. Maybe have those people return to work. Additionally, what we have right now, we have people who are very valuable to the smooth functioning of the economy, scientists who develop vaccines, you have law enforcement, you have firefighters. So maybe have some kind of score based on how valuable it is to have a person back. And what people have already discussed in the past is that in some fields, like let's say farming or construction, you could probably return to work safely and not be at a close distance to other people. So maybe have those people return to work. And what obviously we know about COVID-19, I used a lot of assumptions for pandemic flu, but what we now are starting to understand about COVID-19 is that people who are survivors of coronavirus, they may have long-term health consequences, which I have not quantified. So then we should take those into account and add them to the costs. And if they're in fact very expensive long-term consequences to people's health, then we should actually extend the suppression to a longer period of time to prevent even more people from getting sick. Just to summarize, if we do the lockdown right, it's a really important tool that we could achieve our objective to reduce the number of people getting sick now and in the future, reduce the number of deaths. We could actually benefit the economy tremendously to the order of about 17% of the US GDP. Just the last slide, additional references, some additional readings. So if you're interested, I have the paper, which is posted on SSRN. If you're interested in looking at the famous Imperial College paper, I have a link here. The National Roadmap to Reopening by Scott Gottlieb and colleagues is also posted here. I like to look at Paul Romer's webpage. He's doing some simulations. And then finally, if you want to contact Shane or me, I have our email addresses. And thank you again for listening. So if you have any questions, we'll just go back to Shane right now.
Yeah, thank you, Anna, for going through that. I've actually heard from a lot of folks who are really grateful and just acknowledging this great work in your presentation. So thank you first. I'm gonna give you 3 questions just to try to get to as many as we can in the short time we have, and you can answer however you're able in the few minutes we have. The first, there is a question, going back to, you don't have to go, but to an earlier slide around the phases you mentioned. Obviously, one is to prepare for the next pandemic the best we can. There has been reporting or acknowledgement that maybe the current administration might have not followed some previous pandemic plans from a previous time. So how does government, if this happened again, ensure we are actually prepared and can follow through on recommendations? That's number one from your perspective and how the economic models dictate some of that. Number 2 is we have a PhD class of 2014 alum, Vina, who works at the IMF, who has a question on lockdown exit strategy. If R0 is hard to calculate in real time, but we have the ratio of new cases to cumulative cases, can you translate your assumptions on R0 to this ratio that governments can use to have a timeline to exit the lockdown? Let Vina or me know if that is clear or not. And then the final question I have here, Anna, if you don't mind, is how robust are the results compared to using other basic epidemiological models? And then I'll pause there and see if we get any more in the next couple minutes.
Okay, yeah, thank you very much for all these questions. So the first question, how to prepare for the next pandemic? I think our supplies got somewhat depleted with the swine flu and somehow never restocked. So I don't really know where the failure came from. But when I was working on biothreats, specifically on pandemic flu, I was actually quite happy that somebody is working on it. And there were a lot of agencies involved. There was money being spent on trying to find new vaccine technologies. And I was actually quite happy that people were really thinking carefully about pandemic flu and understanding that that's a real threat. So I don't really know where the failure came from in terms of coronavirus, why people were not preparing for the novel coronavirus. But I think the easiest way to do it is just to, after this pandemic is over, hopefully soon, just restock everything. So restock the ventilators, restock the face masks, restock everything that we have depleted. And then continue just expanding the horizons beyond just pandemic flu, just think about coronavirus and maybe any other infections and do tabletop exercises on those and do the scenarios, what could happen in case of those other pandemics. The second question, I think, was about R0, how to calculate R0. Yeah, so I think one could look at the data. So if one has really good data and one can do in the number of new cases by week and has a lot of good data in terms of testing, that you really are testing a lot of people, then it should be very easy to calculate, right? So if you know that one person is infectious for 2 weeks, and then you see what the initial number of cases were, and you see what the number of cases is in the next 2 weeks, you could actually back this out from data. But we don't have good data, and that's our problem right now, just because not too many people get tested. And it's really hard to know. Maybe somebody knows, but I just don't have the good data right now. And the last question was about government. Shane, what was the last question?
How robust are the results compared to using other basic?
Right. Yeah. So I have a very simple model. In my simple model, this is really what I need to just show what I want to show. I assume that everybody mixes with everybody else. You know, a person in Boston can meet a person in California, and that's probably not realistic. So people who do the epidemiological models, they probably have geography-specific models, because we know that probably we in Boston can meet other people in Boston, but we don't really travel right now that much outside of Boston. So I think you could have a real improvement on my simple model by incorporating the geographical element. How, you know, and that's why people, in terms of mitigation, they say maybe we could do this mitigation by geographical region. Maybe in some rural areas where the population density is not that high, we could let people, and there are not a lot of new infections, and we know people don't travel in and out of this area that much, like maybe somewhere up in Maine, maybe we could let those people go back to normal, but maybe not in New York City, because the population density is so high and the chance of just running into somebody on the street is so high and so many people are infected. But people with from Maine and from New York, they probably don't mix that well, especially if we discourage travel. So I would say that's a really clear way in which this model that I have can be improved.
Anna, this might be our last question. One more from Jennifer, who's an MBA alumna. She's curious how effective you think certain financial innovations such as pandemic bonds may be in terms of fighting current and future pandemics.
Yeah, I don't know. Actually, I should read about this innovation. I haven't read about this. I think financial stimulus is very, very important. How we set it up, how we structure it is going to be extremely important in terms of not getting into a deep recession, because we know some people cannot work right now. They're running out of savings. They're losing jobs. Maybe they're just kind of losing houses, apartments. So we need to find a way to support those people right now through the hardship, because we know it's for the common good, and we will come out on the other side. And hopefully the personal balance sheets are not going to be too much weakened, and same with corporate balance sheets. That's why we're doing all these cheap lending to small businesses, because we know that the number of customers has decreased. So we don't want all of those businesses to go bankrupt. We don't really want people to go bankrupt, because we know bankruptcy is just a dead weight loss to society. It's like a loss of intellectual property, a loss of assets. So we want to, structure the stimulus the best that we can.
Thank you. I'm going to give us 10 more seconds. If I don't see any more questions, we'll sign off, Anna, but giving folks one more chance. Okay, well, Anna, do you have any final words before I close this up?
Yeah, well, thank you so much for participating. And it's actually something that is so important for us. I really hope we could get it right. And I really hope so much that we could prevent people from dying in the future. This is so important right now to really try to get it right. And thank you so much for all thinking about it, how to do it.
Yeah, and I, of course, will echo that. Anna, thank you for doing what you've done to bring light to this situation and in your previous work and obviously in your current work. We're grateful to have you here at the Brandeis International Business School. And I want to point folks to this final slide that's currently on the screen. We will follow up with an email with links to Anna's paper. And then also we are recording this session, so we're happy to share this, and you can let us know if you want us to share it with some other folks. We'll put it on our website. You can feel free to email me, sdunn@brandeis.edu, or Anna, if you have questions or are looking for resources. I heard from folks during this session that they're eager to follow up. So Anna, hopefully you'll get some emails after this. I want to let everyone know, just finally, especially our alumni who are still on the call, again, in this this new environment, new world, Brandeis University, including the business school, we're planning a range of events in the next several weeks and months and beyond to engage alumni with a range of topics and social opportunities. So be on the lookout in your email. Reach out to us if you have any ideas. One event the business school is hosting next week is about leading organizations through crises, which is what we're going through right now with a couple of our more distinguished alums, as well as Dean Katie Grady. So be on the lookout for that, and we hope to bring more programming to you in the future. In the meantime, stay safe, stay healthy, and again, thank you for joining us today, and have a great day.
Thank you.